So picture the scenario. You're, I don't know, walking through your house, maybe you're distracted by your phone, and wham, you bang your elbow really hard against the edge of a door frame.
Oh, worst.
Right. It sends that terrible radiating shock right up your arm. But think about what you actually do in that exact second.
You grab it.
Exactly. You don't just stand there like arms at your sides analyzing the pain. Your immediate, almost primal instinct is to grab your elbow and just start vigorously rubbing it.
Yeah, it's a completely universal human reaction.
Mm-hmm.
I mean, whether you watch a toddler take a tumble or, a professional athlete take a massive hit on the field, the very first response is physical pressure.
Massaging the area.
Massaging it, yeah.
Mm.
We do it without even forming a conscious thought.
And we do it because on some intuitive level, we know it actually helps the pain. But the wild part, and the reason we're talking about this today, is that this simple unconscious instinct to rub a bumped elbow is, well, it's the foundational concept for an entire field of high-tech medical treatments.
It really is.
So today's deep dive is taking us straight into the world of neuromodulation. We are looking at how doctors are using electrical and magnetic nerve stimulators to treat some of the most debilitating systemic headache disorders on the planet.
Yeah, and we have a really great stack of clinical resources today originating from the Migraine Surgery Specialty Center. And our goal here is to basically map the evolution of this technology for you.
Right.
We're going to trace the history of hacking the nervous system with electricity, examine the actual devices themselves, which, by the way, range from non-invasive wearables all the way to really complex surgical implants.
Which are fascinating.
Oh, absolutely.
Yeah.
And then we need to look at their very real limitations. Because as incredible as neuromodulation sounds on paper, the physical reality of putting hardware inside the human body is, well, it's complicated.
It's very complicated. And finally, we're going to explore a surgical option for when the electricity just isn't enough. For patients who have, failed multiple medication classes where migraines or cluster headaches dictate every single aspect of their lives, this topic isn't just some cool science fiction concept, it's a potential lifeline. Okay, let's unpack this.
So,
We have to start with the history, because to understand how we treat a complex neurological event like a migraine with electricity today, we have to look back at a revolutionary theory from 1965.
right, which takes us to Ronald Melzack and Patrick Wall. They published what they called the gate control theory of pain.
The gate control theory.
Yeah, and to put it in perspective, before 1965, the medical consensus essentially viewed pain as like a straight, uninterrupted wire from the injury directly to the brain.
Like a direct alarm bell.
Exactly.
Yeah.
You touch a hot stove, the stove is hot, signal travels straight up that wire, and the brain registers pain. Boom. But Melzack and Wall, they proposed something much more dynamic. They suggested that non-painful sensory input, like the pressure and movement of rubbing that bumped elbow you mentioned, actually activates large diameter nerve fibers.
Okay.
And when these large, really fast-moving fibers are activated, they literally close the gate on the slower pain signals down at the level of the spinal cord.
So it's kind of like a traffic jam scenario.
That's a good way to look at it.
You're just flooding the communication network. If the slow pain signal is trying to get through the spinal gate to the brain, you just overwhelm that exact same gate with fast, non-painful rubbing signals.
Exactly. The pain signal basically gets blocked out. It's crowded out of the system before the brain can even fully process that it hurts.
That is wild.
It is. And that is the exact mechanism. They hypothesized that if we could artificially activate those specific fast-moving nerve pathways using electricity, well, we could effectively close the gate on pain perception on command.
Just zap the gate closed.
Pretty much.
Yeah.
And it didn't take long for the medical community to jump on this. By 1967, we saw the introduction of spinal cord stimulation for chronic pain management.
But getting this to work for the head and neck, that took a lot longer, right?
It did. The documents highlight 1999 as a major milestone there. Two doctors, Weiner and Reed, decided to try occipital nerve stimulation, or ONS, on patients suffering from occipital neuralgia.
And if you've never experienced occipital neuralgia, it sounds awful. Imagine severe electrical shocks radiating right at the back of your head and over your scalp.
It's incredibly painful.
Yeah.
So Weiner and Reed, they took subcutaneous electrodes, meaning they literally threaded wires just under the skin.
Oh, wow.
Yeah, they placed them right over the occipital nerves at the back of the head and turned on a mild electrical current.
And what happened?
The results were profound. They demonstrated a meaningful, sustained reduction in pain. I mean, it was this massive proof of concept that just triggered a wave of interest across neurology. Researchers immediately started asking, could this mechanism work for refractory migraines or even cluster headaches?
Okay, wait, let me pause you right there because this brings up a massive logistical question for me.
Sure.
I totally understand how stimulating a nerve at the back of the head helps with pain radiating up the back of the head. That makes sense.
Right.
But a migraine isn't just a headache. It's a systemic neurological event. And sufferers often experience terrible, throbbing pain right behind their eyes or deep in their temples.
Yes, very common.
So how does zapping a nerve at the base of the skull do anything for pain going on in the front of the face? It feels like we're treating the wrong zip code.
What's fascinating here is a piece of deep anatomy called the trigeminocervical complex.
The trigeminocervical complex.
Try saying that 3 times fast. But think of it as a major neurological junction box located deep in the brainstem. You have your cervical nerves from your upper neck, specifically C1 through C3, and you also have your trigeminal nerves, which rely all the sensation from your face, your eyes, and your forehead.
Right.
Well, all of these distinct nerve fibers travel down and physically converge at this single junction box.
Oh, I see. They are plugging into the exact same switchboard.
Exactly.
Hmm.
Because of this anatomical convergence, if you stimulate the cervical nerves at the back of the head, that electrical signal travels down to that shared switchboard. And the brain essentially gets confused, but in a therapeutic way.
Interesting.
The electrical input from the back of the head modulates that central pain processing center. Right. And it just turns down the volume on the pain that is actually being generated or felt in the front of the face.
So we're literally cross-wiring the brain's pain network to cancel out a migraine.
That's one way to put it, yeah.
That is just brilliant. So if we know the brainstem can be tricked like this, the obvious challenge becomes, well, how do we actually get the electricity in there safely?
Right, the delivery method.
And the gadgets detailed in these sources generally fall into 2 categories, right? Non-invasive and implantable.
Correct.
Let's start with the non-invasive ones.
Well, non-invasive devices are generally considered the first-line option in neuromodulation, simply because the safety profile is just excellent. I mean, there's no surgery, no recovery time.
Makes sense.
A prime example of this is the Cephaly device. Have you seen these? It's an external trigeminal nerve stimulator.
I think so. It looks kind of like a small metallic headband, right? Or almost like a Wonder Woman tiara.
Yeah, exactly.
Yeah.
You place a self-adhesive electrode pad directly on the center of your forehead, and it targets supraorbital branches of that trigeminal nerve we were just talking about.
Okay, I have to be the skeptic here for a second.
Go for it.
You're telling me a glorified vibrating sticker on the forehead actually stops a severe neurological disease? Like, how do we know this isn't just a massive placebo effect? People are desperate to feel better, so they put on a device and just convince themselves it's working.
It is a totally fair question, and it's exactly why clinical trials use what we call sham devices.
Sham devices.
Yeah, fake stimulators that look and feel similar. They even buzz a little, but they don't deliver the actual therapeutic current.
Okay.
So in the Primus trial, they tested the Cephaly device specifically for migraine prevention. They had 67 patients use either the real device or a sham device daily.
And the results?
The group, using the actual Cephaly, saw a statistically significant reduction in migraine days per month compared to the placebo group. On average, they saw about a 2-day reduction in migraines every single month.
2 days. I mean, 2 days might sound a little minor to someone who gets a mild headache like once a year. But for a chronic migraine patient who is losing 15 or 20 days a month to debilitating pain, the nausea, the light sensitivity.
Oh, it's life-changing.
Yeah.
Calling back 2 completely clear functional days is a massive quality of life improvement for them.
Absolutely.
And then you have devices targeting entirely different pathways, like the gammaCore.
The cam?
Yeah, and you don't put this one on your head at all. It is a handheld device that you actually press against your neck to stimulate the vagus nerve.
Okay, the vagus nerve. That's essentially the superhighway of the parasympathetic nervous system, right? The whole rest and digest system.
That's the one.
But wait, it controls heart rate, digestion, a lot of involuntary functions.
Yeah.
How does stimulating the neck stop a migraine in your head?
So when you deliver the specific electrical pulse of the gammaCore to the vagus nerve, it activates these descending pain inhibitory pathways. It basically sends a signal up to the brainstem, commanding it to release its own endogenous opioids and monoamines to suppress pain.
Hold on, monoamines, what are we actually talking about in this context?
We are talking about neurotransmitters like serotonin and norepinephrine.
Oh, got it.
Yeah, it's like your body's internal pharmacy.
Yeah.
By stimulating the vagus nerve, you're essentially forcing the brain to dump these natural pain-relieving chemicals into your system.
That's incredible.
And it works quickly. In the Presto trial, they found that if patients used the gammaCore within 20 minutes of a migraine attack starting, they had significantly higher rates of being totally pain-free at the 30 and 60-minute marks compared to a placebo.
Rapid pain freedom. I mean, that is the holy grail for an acute attack.
It really is.
And there is also the spring TMS, right? Which abandons electrical currents on the skin entirely.
Yeah, that one uses a focused magnetic pulse delivered to the back of the head. It's FDA cleared for migraines with aura.
Right, and the sources explain it works by interrupting what they call cortical spreading depression.
Exactly.
And for you listening, think of cortical spreading depression like a rolling electrical blackout moving slowly across the surface of your brain. That rolling blackout is what causes the visual aura, the flashing lights, and eventually the actual pain.
Yep. And the magnetic pulse essentially acts as a circuit breaker to just stop that rolling wave in its tracks.
That is so cool. But here's where it gets really interesting. There is a device called Neurevio, and you don't wear it on your head, and you don't hold it to your neck.
Nope.
It's an armband. You strap it to your upper arm to treat a migraine. Walk me through the logic of that, because sounds crazy.
It does sound crazy, but it exploits this deeply ingrained biological phenomenon called conditioned pain modulation.
Conditioned pain modulation.
Yeah. It's your body's natural systemic mechanism where pain in one area of the body actively inhibits the perception of pain somewhere else.
Wait, really?
Yeah, they're basically fighting fire with a very controlled, low-level electrical fire.
Oh, so it's kind of like biting your lips so you don't focus on an injection at the doctor's office.
Exactly like that, just on a much more sophisticated neurological level. By delivering a specific electrical stimulation to the peripheral nerves in the upper arm, the Neurevio device hacks those central pathways.
Yeah.
It tells the brainstem, hey, there's a strong signal coming from the arm, which forces the brain to release those global pain-relieving neurotransmitters we talked about earlier.
Which, in turn, shuts down the migraine generator in the head.
Precisely.
That is just elegant engineering.
Yeah.
But as remarkable as these wearables are, sometimes patients have refractory conditions where external stimulation just doesn't penetrate deeply enough or, the relief doesn't last.
Unfortunately, yes.
And that takes us to the second category, the implantables. This is where we leave the wearable tech behind and actually enter the operating room.
Right.
Let's revisit occipital nerve stimulation, or ONS, that we mentioned earlier. How do surgeons actually install this system today?
So it is a heavily involved, invasive procedure. Surgeons implant small paddle or cylindrical electrode leads just under the skin at the back of the head, resting right over those occipital nerves.
Okay.
But those electrodes need a power source, obviously, so they have to physically tunnel wires beneath the skin, all the way down the back of the neck, to an implantable pulse generator.
Tunneling wires?
Yeah, under the skin. And the generator is basically a pacemaker battery pack surgically placed in the chest, the flank, or sometimes even the buttock.
Wow. So a patient has wires literally running from their scalp, tunneling all the way down their neck and torso to a battery pack.
Yes, they do. And the patient is given a handheld remote to control the stimulation so they can adjust the amplitude or the pulse with themselves.
And what does it feel like?
When it's active, they typically feel a constant tingling or a buzzing sensation called paresthesia right at the back of their head.
Does it work?
The clinical data from trials like the on-end STIM trial showed that roughly 39% of patients with active stimulation achieved a 50% reduction in their headache days.
I mean, cutting headache days in half for nearly 4 out of 10 patients who have failed every other medication on the market, that is substantial.
It's huge for those patients.
But the sources detail an even more extreme intervention. There is a device called the Estis-G Pulsante microstimulator.
Oh, yes.
And this is designed specifically for cluster headaches. And for context, cluster headaches are frequently referred to as suicide headaches because the pain is just so unbelievably severe, usually localized behind one eye, that patients literally often cannot sit still.
They'll pace the room, bang their heads against the wall. It's horrific.
So where does the surgeon implant the SPG Pulsante for this?
It is implanted directly through the roof of the mouth.
Through the roof of the mouth? That sounds almost barbaric.
I know it sounds extreme, but it is actually anatomically very precise. The surgeon implants the microstimulator through the greater palatine canal in the mouth to directly target the sphenopalatine ganglion.
Okay, the sphenopalatine ganglion.
Right. Think of it as a major neurological traffic hub for facial pain signals located deep behind the cheekbone.
Got it.
It plays a massive role in the autonomic symptoms of a cluster headache.
Yeah.
The tearing eye, the nasal congestion. So targeting it directly is highly effective.
And the data on this one?
The ACT1 trial showed that over 67% of cluster attacks were either fully relieved or significantly reduced with this device.
Over 67%. So we have a device cutting cluster attacks by 67% and ONS reducing severe migraines by 50% in a large cohort. The numbers look really great.
On paper, yes.
But here is the critical transition in our analysis today. A 50% reduction sounds like a total miracle, yet ONS is still not FDA approved for migraines.
It's not.
It is considered a treatment of absolute last resort. Why? This brings us to the catch. The harsh reality of installing rigid hardware inside a mobile human body.
Yeah, the complication rates for implantable nerve stimulators, particularly ONS, are honestly daunting. The primary culprit is hardware failure, specifically an issue known as lead migration.
Lead migration.
Right. Remember, these electrodes are implanted directly under the scalp, and the human scalp is highly mobile tissue.
Yeah, I guess it is.
Think about it. Every time you turn your neck to check a blind spot while driving, every time you chew your food, talk, or just simply roll over on a pillow while you're sleeping, your scalp moves.
So the skin is sliding over the skull, but the wires are, what, trying to stay in one place?
Exactly. And because of that constant daily friction and mobility, the clinical data shows a staggering 30 to 40% of patients experience lead migration.
30 to 40%, that's huge.
It is. The wire physically slips away from the targeted nerve, and the moment that happens, you lose the therapeutic pain relief.
And how do they fix it?
The only way to fix it is to go back into the operating room for a revision surgery.
A 30 to 40% failure rate requiring surgery to fix? That's rough. And the batteries, they don't last forever either, right?
No, they don't. The implantable pulse generators require battery replacements every 3 to 5 years.
More surgery.
More surgery, more anesthesia, more risk. Wires can fracture from the constant bending of the neck. Connections can fail. And frankly, anytime you have foreign hardware in the body, there is a risk of infection.
Right, of course.
Deep infections usually require the entire device to be explanted, meaning fully removed, which occurs in about 10 to 20% of long-term cases.
Add in the fact that because it's not FDA approved for migraine, the sources note it is prescribed strictly off-label.
Oh, the insurance aspect is brutal.
Right. It turns the process into an absolute nightmare for patients fighting with insurance companies. They fight for months to get coverage for the initial surgery and then have to fight the exact same battle every single time a wire slips or a battery dies.
Exactly.
Using an implantable nerve stimulator, it's kind of like putting a mute button on a blaring fire alarm.
That is a really, really apt analogy.
It makes the terrible screaming noise stop, which is obviously a profound relief when you are trapped inside the burning house, but it doesn't actually put out the fire.
No, it doesn't.
It is palliative, not curative. The underlying physiological issue causing the headache is still there, raging away. You just can't feel it because the electrical buzzing is masking it. And if you turn the stimulator off, or if that wire slips just a few millimeters,
the migraine comes roaring right back. Because the source of the problem was never actually addressed. And this raises an important question, especially when we look at these massive trials for episodic migraines. It raises a deeply troubling question about who is actually being left behind.
Yeah, the sources dedicate a lot of ink to what they call the invisible patients.
Yes. There is a systemic flaw in how the medical community develops and tests these neuromodulation treatments.
We're talking about people dealing with constant, daily, unremitting headaches, conditions like NDPH or new daily persistent headache.
Right.
And if you listening aren't familiar with it, NDTH is a nightmare condition where a person wakes up one day with a headache and it literally never goes away. Not for a day, not for an hour, it stays for years. And these patients, who are arguably suffering the most, are systematically excluded from almost all clinical trials for headache devices.
They are. And they're excluded because clinical trial methodology heavily relies on discrete counting.
What do you mean?
Researchers need to measure episodic attacks to prove mathematically that a device works. The standard protocol is count your headache days for a month, then use our stimulator, and then count your headache days again to see the reduction.
Oh, I see.
Right. But if a patient has a constant 24/7 headache, they don't have episodes. They just have one continuous agonizing event. So because they don't fit the spreadsheet's rigid requirement for a baseline, they just get disqualified.
Which means these desperate patients who are in constant pain are left to just cycle through these expensive, invasive surgeries with absolutely no clinical evidence base tailored to their specific condition.
It's terrible. The medical infrastructure was basically built to measure a completely different phenotype of headache.
It is a devastating blind spot in headache medicine.
It really is.
Which brings us to the final and frankly most fascinating section of our deep dive today.
Yes.
If the stimulator is just a mute button on the fire alarm, how do we actually pull the burning logs out of the house? What if the nerve is screaming not because of a chemical imbalance in the brain, but because it is physically being crushed?
This is where the paradigm totally shifts from neuromodulation to surgical anatomy. Because for a significant subset of headache patients, the generator of their pain is actually structural and mechanical.
Mechanical.
Yeah. A peripheral nerve in the head or neck is literally being compressed, kinked, or irritated by adjacent muscle, bone, or fascia.
Enter Dr. Bauman Goiron.
Yes.
He is a plastic surgeon, which at first glance seems incredibly counterintuitive for complex headache treatment.
It really does.
But he pioneered this entire field of peripheral nerve decompression surgery, and he did it based on a total accident.
A brilliant accident.
He noticed that patients coming to him for purely cosmetic brow lifts were suddenly reporting at their follow-ups that their lifelong chronic migraines had just vanished.
Just gone.
Gone. And he realized that by altering and removing small portions of the frown muscles in the forehead during the cosmetic procedure, he was inadvertently unsqueezing the nerves that were triggering their migraines.
And to his credit, he didn't just ignore it.
Yeah.
He took that clinical observation and spent decades mapping the anatomy, identifying exactly where these nerves tend to get trapped.
And the sources outlined 4 primary anatomical trigger sites, right?
Yes. Site I is the frontal region. They get physically pinched by the corrugator muscles. Those are the frown muscles right above your eyebrows.
Okay.
When these muscles contract, they can literally squeeze the nerve passing through them. Patients with this trigger typically describe a really heavy, imploding forehead pain.
Then there's site 2, the temporal region. This involves the zygomaticotemporal nerve at the site of the head. And the sources say these patients often wake up with severe temple pain. Why? Often because they suffer from bruxism, meaning they grind their teeth at night.
Exactly. And when you constantly grind your teeth, the temporalis muscle bulks up. It hypertrophies, just like a bicep doing curls at the gym.
Right, and that enlarged muscle just clamps down directly on the nerve.
Yep. Then we have site 3, which is rhinogenic, meaning the compression originates inside the nasal cavity. The branches of the trigeminal nerve get compressed by structural issues in there, like a severely deviated septum or enlarged turbinates.
Turbinates being the bony structures inside the nose that warm and humidify the air we breathe, right?
Correct. When those turbinates swell up, say, due to weather changes, barometric pressure drops, or even severe allergies, they expand and physically pinch the trigeminal nerve branches inside the nasal cavity.
Ouch.
Yeah, these patients often describe an explosive stabbing pain deep behind the eye.
And finally is the occipital region, the back of the head.
Right, where we started.
The greater occipital nerve gets trapped by tight, rigid neck muscles, which is very commonly seen in patients who have a history of whiplash or a neck injury.
Exactly.
And the surgery to fix these issues, it doesn't involve implanting battery packs or tunneling wires. The surgeon simply makes a small incision, locates the compressed nerve, and carefully cuts away the tiny piece of muscle, bone, or fascia that is squeezing it.
They just free the nerve, giving it room to breathe.
And the clinical evidence supporting this is incredibly robust. Dr. Guyeron published a landmark sham-controlled surgical trial in 2009.
Which is huge. Performing a placebo-controlled trial for an actual surgical procedure is exceptionally rare and really difficult to pull off ethically and logistically.
But he did it. And the results showed the surgical group had an 83.7% positive response rate.
Amazing.
Even more remarkably, 57.1% of the patients experienced complete elimination of their headaches. Not just a 50% reduction in days, but total elimination.
Complete elimination. The fire is literally out.
And the sources point out a really fascinating diagnostic tool to predict who will benefit from this surgery: Botox.
Oh, yes. The Botox test.
If a patient gets targeted Botox injections in these specific trigger sites and their migraines temporarily stop, it is a massive green light for surgery.
Because Botox temporarily paralyzes the muscle. If the pain vanishes when the muscle is physically unable to squeeze the nerve, well, it proves beyond a shadow of a doubt that the muscle squeezing the nerve is the root cause.
Right. Decompression surgery just goes in and makes that temporary muscle relaxation permanent.
It perfectly validates a symptom-based patient selection process. You map the patient's specific symptoms to the anatomy, confirm it with a nerve block or Botox, and then decompress the target nerve.
So what does this all mean for the patient who has already gone through the ringer? The patient who, say, had an occipital nerve stimulator implanted, got a year of relief, and then the wire slipped.
Right.
Or the patient who only ever achieved like a 30% reduction in pain with the device. Traditionally, that is viewed as a failed treatment, a dead end.
The clinical failure, yeah.
But in the context of decompression surgery, the sources highlight this beautiful paradox that failure is actually a diagnostic goldmine.
It is a critical pivot in how we view treatment data.
Hmm.
The stimulator, even a broken one, confirms the target.
If the stimulator proves the nerve is the problem, but the stimulator itself is just a faulty mute button that keeps breaking, the logical next step isn't just to throw your hands up in defeat.
Wow.
The next step is to find out exactly where that nerve is being compressed and go unsqueeze it.
Exactly. It makes that failed stimulator patient an incredibly strong candidate for decompression surgery. It takes a palliative masking therapy that ultimately failed and turns it into a highly precise roadmap for a potentially curative surgery.
We have covered a tremendous amount of ground today. We started with the basic primal instinct of rubbing a bumped elbow to close the spinal pain gate.
We did.
We looked at the modern evolution of that theory, wearing electrical armbands to trick the central nervous system and implanting microstimulators straight through the roof of the mouth.
Still wild to think about.
We examined the sobering reality of hardware failures, migrating wires, and the patients left behind by clinical trial designs. And finally, we arrived at the elegant anatomical solution of simply freeing trapped nerves from physical compression.
And, if we connect this to the bigger picture for neurology, this represents a massive paradigm shift.
It really does.
For decades, the prevailing view has been that migraines are almost exclusively a chemical imbalance, a systemic disease that must be treated with systemic whole-body medications.
Right. Treating the whole body for a local problem.
Recognizing that severe chronic headache disorders can actually be an anatomical structural problem. A literal physical pinching of a nerve completely changes how we approach pain management.
It takes something invisible, systemic, and totally mysterious and makes it tangible. A physical problem with a physical solution.
Exactly.
And that leaves me with a final thought for you to ponder as we wrap up today's deep dive. If medical science is just now fully realizing that some of the most severe chronic migraines on the planet might actually be caused by mechanical compression, a physical pinching of a nerve rather than just a chemical storm in the brain, it makes you wonder.
It does.
How many other mysterious, invisible chronic pain conditions in the body are we treating with endless rounds of heavy medication, when the root cause might just be a millimeter of muscle squeezing a little too tightly on a nerve? Thank you for joining us on this deep dive. Keep questioning the consensus, keep looking for the structural root causes in your own life, and we will catch you next time.